Our little corner is at Cvph Medical Center again. Every time we come back, it's like old home. Todd Krampitz, how are you?
Wonderful, Gordy. It's nice to have you with us.
I see him 3 or 4 times a year in the most interesting disguises. He was like a little helper over the Christmas holiday, snapping pictures as I came and helped Santa Claus through the line at Christmas time here at Cvph Medical Center, and we discussed before our camera started how many youngsters decided to take advantage of that. Your little figure must have been...
We had approximately 120 children and some adults that came in and wanted their picture taken on our open house at Christmas time. It's lots of fun, and it's nice to be part of the
I
community.
just don't want people to think it's all serious here at Cvph Medical Center. We have to have a little levity every now and again to stay sane, don't we?
That's right. That's right.
Todd, what is your title again here?
I'm the Director of Diagnostic Services, which means I get to be in charge of radiology and laboratory.
And see the sign right behind us. This is a program that we've wanted to do for a long time, and I'm so glad we came here today because what you have offering to the public here is so exciting. And what you accomplished in a short period of time is beyond superhero status.
I don't know about that, but we are really proud. All the employees just did a super job, and we're able to continue to provide really exciting services during the time we install both the CT and the MR. We've got 3 pieces of equipment that are just astounding, as you talked about. The CTs are maybe 1 or 2 of 100 in the world, and the MR, when it was installed 90 days ago, was 1 of 12. And so we're very fortunate. When they talk about state-of-the-art equipment, we're very fortunate here in Plattsburgh. We don't have to travel a real long distance to get the best medical care there is, and we're really excited about that.
We'll do a lot of shop talk here today, but I will stop people every now and again for complete explanations because many of our viewers have no idea what CT, MR, MRI, R2,
and all the alphabet soup is. Well, MR is magnetic resonance imaging, and that's what you see a lot of the athletes having now. If they hurt their shoulder or their knee, they get hauled off, and used to be they had an x-ray. Well, now for a knee or shoulder, they generally have an MRI done. And CT is computerized tomography. That's a computerized x-ray machine, and you get a chance to see those later. CT is becoming much more common than it ever used to be. It used to be kind of a space age thing. Now it's getting just common and routine. It's like having your computer at home. You know, it used to be really strange to get electronic message across. Now we can't live without it.
Sometimes we would love to be able to.
Yeah, we understand that delete key a lot.
Oh boy, I'll tell you. Yes, I've become attached by some invisible cord to my computer, answering a huge number of emails every day and doing research, and you have to kind of rip yourself away from it. But modern technology is amazing and wonderful.
Yes, it is. There's things that just a couple of years ago we hoped we could do. Vascular imaging with MRI. And MRI does not use radiation. It uses a magnetic field and radio frequency to produce the images. And there's many reasons that Liza's going to show you about a little bit later. And it's just so exciting to be able to do these things. And you watch the 6 o'clock news, and the news people come on and say, these are the latest and greatest medical developments. And you think, wow, I wonder where I have to go to get those. They're right here. And, you know, I always talk something very silly about the mother test. You know, if my mother was ill, where would I want her to go? And she'd come here. She'd come here. And I'm very pleased about that.
We spend a lot of time talking about this Cvph Medical Center as being a regional medical center, and it lives up to its name. You know, the health field, as many of our viewers know, is going through a metamorphosis. Some things we didn't predict, some things we did, some things are out of our control, and some things we're working like crazy to improve. But this medical center remains quite stable in the services that it offers, and that's the bottom line as far as John Q. Public is concerned.
I think that's right. We took a look a couple of years ago. We had one CT scanner, which we're very proud of. It was very new and very fast, a dramatic improvement over the past. But as a lot of the care goes to outpatient care, you know, being in the hospital is almost a rarity nowadays. Everything's done as an outpatient, and we're committed to that outpatient care. We've constructed the Cvph Medical Plaza across from Hannaford's, and that has has just been really neat.
I still call it the paper cutter. I don't
Yeah,
care
the
what-
paper cutter building, yeah, well, I'd say across from Hannaford's and everybody knows. But we're real pleased. People get to walk right in and walk out. We had one of my own employees call me up. She was so excited that if she advance registered and gave them all the information, name, rank, serial number, and she walked in, had her CT done, and was out back in her car in 30 minutes. So
Think about that in the old days.
it used to be that the scan itself took 30 minutes. And now the amount of information is so dramatic, and Liza, who's our wizard when it comes to this stuff, she's going to show you, she's going to show you some of the things that we can do. Might even be space age and how you see things constructed in 3D, and we can rotate images and show you some vessels and things that you never thought could be done before. But the whole idea is to be able to, it's faster, better, cheaper, quicker, and is to get people in here, get them out, and not have to undergo surgery to find these things out, and give your doctor the best information they can get.
The easier it is for us to look inside the human body,
right.
find out what's going on here, the less times we have to
That's right.
cut and slash and sew and fix and...
And that's risk. Our whole goal here is to decrease the risk to the patient. Anytime you go stick a needle into somebody or have to cut into them, there's a certain level of risk with that. And if we can do it without radiation or with as little radiation as possible, and of course as fast as possible, that's really nice. I don't think any of us want to be injured or compromised in any way, and so we're real excited about what we can offer.
Liza,
Yes,
you haven't hardly said a word until now. How are you?
I'm very good.
Liza
very good.
Rushford, we're so pleased to meet you. What is your job here?
I'm the CT MRI supervisor.
It's interesting for both of you to realize, and for Calvin and me, that our programs kind of run the historic timeline because we've interviewed old doctors. We had so much fun during the Diamond Jubilee, interviewing the retired old doctors who eat out, the rodeo doctors, and then doing a series of programs with the legendary A.B. de Grand Prix,
Yes.
and talk about what they had to work with.
Right.
Back in the old days in the 30s and 40s and 50s. And the phrase, "we've come a long way, baby," really applies, Liza, doesn't it?
It does. I've been at Cvph almost 9 years now. The technology is rapidly changing. And the hospital has been changing with the technology, but it's changed in 8 years, unbelievable. I was here when a CAT scan used to take a half hour to do. We used to book a patient every hour because an abdomen and pelvis, which is when we scan the belly of a patient, used to take an hour. And now we're scanning an abdomen and pelvis within 5-10 minutes. You're on the scanner, not even that.
Yeah, and speed is important. We talked about, the facility of being able to see things better, but speed is very important. When you got somebody who's a hurting machine, we got to find out what's going on in there real quick.
That's right. We've expanded our emergency room in the last couple of years, and the volume in the emergency room has doubled. And it's
The
gotten...
public doesn't know this until they come in here. It's amazing. This emergency center
Right.
is a very, very busy place.
And one of the reasons that we put a CT scanner at the plaza is so we don't mix the outpatients and the emergency patients. It's easy to understand when they say, "I'm sorry, you have to wait a minute while we do an emergency patient." But the amount of car accidents that go on and the injuries that go on, we see them all. And so every time you read in the paper that somebody's injured, they've been on our CT scanner. And so that goes up every day. And what we're interested in is get them in and get them done as soon as we possibly can, so nobody's at risk.
We're going to do a fun tour today. We're going to learn so much. All of us are going to learn so much. But before we start, we know this guy's background, but we don't have yours.
My
Where are you
background?
from? You're from the North Country.
I'm from the North Country, born and raised in Lime Mountain, New York.
Well, all
So
right.
in the mountain, I started the radiology program here at Cvph in 1991. Graduated from the program in 93, but during that time I worked as a clerk here. I was a secretary working while I went through school at the Women's Imaging Center. And when I graduated, I became a technologist here, and I did CAT scans, MRIs, mammography. I was a jack of all trades, worked for a while, and then I just recently stepped into this role as supervisor.
What was your maiden name?
Maiden name was Gonzalez before.
Okay.
And I went to Northern Adirondack School.
Well,
Yeah.
sure.
Yeah.
Isn't that great?
So I'm born and raised here and been in the North Country, love it up here.
Well, it is. We talk about our North Country family, but CVPH is a family too, isn't it?
Very much. It's interesting. Within radiology alone, we have 5 married couples. Both husband and wife work here. And we have employees here, their parents work in other parts of the department. I believe the Martineaus have 5 individuals
Yes,
from their
they do.
families that work here. So when you talk about a family, it's very nice. We have a lot of people that are here, and there's a special bond that's here. So we're real pleased.
And when you have people working so hard, and these smiles belie what goes on in the brain inside, and these people are frantic most of the time. They don't have too many 15-minute coffee breaks in the course of a shift, believe me. So you better have a staff that gets along with each other.
Yes, and it is a staff that works well together, and there's staff that works here, and then they have gatherings after work together. So it's like a family atmosphere. People do get along really well, and everybody, these are people that they went through the radiology program with. So they've been together sometimes 10, 15 years. So they know each other very well. They know their families very well, everybody's children. So it is a family atmosphere here.
That's great. Liza, I can't wait to see what's on the inside. Tell us roughly what we're going to see today.
We're going to look at the MRI department, and we're going to look at the new scanner that we got and show the nice new MRI that we have, what we call short bore. And that means that before, if you ever saw the MRI machine, it was about 7 feet long, so the patient was totally inside of the machine. But now we have a short bore, 1.5 Tesla magnet. That's the best field strength we could get, so we could get the best quality images for the patients. But now we got that field strength, and we have that short bore, so we have the best of both worlds.
I had a
Yeah.
guy, I told somebody we were coming here today, and he said, I was in the Second World War, and I was in the foxholes, and I never had any feeling of claustrophobia until they put me in this. He says, and something was wrong when I got inside that.
For the past 15 weeks since we've got this new MRI scanner, we've only had 5 patients experience claustrophobia.
Really? Oh, that's
And those,
pretty great.
yeah, we're able to offer those patients, we're able to help them through their test we offer minimal sedation. So we're able, if they can't get through it without the sedation, we'll help them get the test they need.
I love it.
Yes.
Well, let's go inside and take a look around. What do you say?
Great. Welcome. Come on in.
Thank you very much. All right, we have all kinds of things on these doors here. Let's stand next to it, and you
Okay.
tell me about all of this.
Okay, MRI uses a strong magnetic field, which is always on. It's never turned off, so we always have to use precautions when we go in the MRI field. There was an incident that happened last year. A young boy got injured while having an MRI. And so when that happened, here at Cvph, we looked at it and said, what can we do to make it even safer for the patients? Because we've never had an incident here. We want to make sure it remains that way. So we put locks on the doors to go into MRI. We want to make sure nobody has access unless there's somebody from MRI with them, so that way safety can be carried out.
There's a tremendous learning curve going on here for you. I can't imagine how much studying you had to do in the last year.
I'm still learning. We all are. The technology's changing a lot. MRI is now becoming the imaging area for heart imaging. So that's something new we're offering in MRI. So everybody's going back and looking at their anatomy, physiology. We're working with the radiologists here. So the learning is it's continuous. It's never going to stop because we always want to advance on the technology that's being offered.
That's terrific. Okay, can we go inside?
We sure can.
Well, let's do it. Okay, we're inside the door. Tell me everything.
Yes, but we are in a safe area where we are right now, and as you come into this area, you're going to see we have a metal detector. So this is our last check before a patient goes in the room. We just want to make sure they didn't forget anything in their pockets, if there's any question about the metal that's within their body. So a patient, before they go in the magnet, we have them walk through a metal detector, just like you have at the airport, but it's their last check for safety.
Stupid question, but what happens if they have metal implants?
That's fine. It's safe for an MRI. It's fair, says no problem. We worry about the pacemaker that's in the body, that's
Yes.
electric, clips, aneurysm clips in the brain. But if you had abdominal surgery and stuff like that, as long as it's been 8 weeks and scar tissue forms, then it's safe for you. But we ask all these medical questions before we even get to this point. About 3 or 4 times, we go through a screening form. We just want to make sure it's safe. But pacemakers, we worry about an oxygen tank getting back here. We watch for that. That's why you have oxygen on the walls. We watch everything that's metal. Like this is something that we worry about, so it is fastened to the wall. Nobody could pull it into the MRI unit. So we have everything very safe back here, but we worry when people come from the outside. If a nurse comes from the floor with the patient, we just go over all the questions with her, let her know the safety issues that are here. But everything's pretty safe in here now.
So much to learn and so
Yeah.
much to do and so much to see. What's next?
What's next? We'll go through, I could let you take a peek at the MRI magnet, and I do
Okay.
have some images of our old MRI magnet. So
Oh,
that
great.
way.
I'd love to see
look
them,
at
sure.
those.
Fascinating learning experience. Don't take time off to go and get a cup of
Right.
coffee, or you might miss something
I
today.
don't know if a good area would be, but this is a patient that was going into the MRI magnet.
Calvin can get those.
Okay. And you could see how the patient was almost totally in the magnet.
So that was
Yeah.
7 feet long. Let's
Yes.
hold them still for a minute. Maybe I can hold them both
We're
with
gonna have a
my,
room flow,
my hand
yeah.
in front of you.
It's hard because of the airflow right here.
Let Calvin just get a little shot of both of those.
Okay.
And that's gone. That machine is not here anymore?
It's not here anymore. Now we have this nice short bore,
All right, I'm coming with you.
and we could go to the doorway, and hopefully
Okay.
Kelvin could see in.
Yep.
Could probably come at an angle.
Okay, let's go this way.
But also, this room is we're concerned about patients being claustrophobic again, so we opened this room up. It was half the size
Oh,
before.
really?
We opened it up,
Yeah.
and we have the nice skylight in there, so people feel like it's a nice open atmosphere. And so it's a lot different than it used to be. As you could tell through the pictures, a little bit darker. Now it's bright. We went with more. People love the plaza up at Hannaford's, so we try to mimic what was at the plaza, make it more an outpatient facility.
Now, is that machine similar to this one?
There's no machine at the plaza for
okay.
MRI, but we have a CAT scan machine up there.
Okay.
Yep. So we try to mimic what was up there for decor, because people like it up there. They like not feeling like they're in the hospital. They like it to be an
I think that's
outpatient.
probably an important thing, and the psychology of being in a hospital is something we've discussed many times before. How they feel about it before they walk into this room is very important.
It's very important because it's taking the time with the patients and how the decor is here to determine if they're able to get through the test. And people realize that, and the technologists here realize that.
And it's really good too, Calvin, because on the door there's a sign that says table weight 440 pounds, so I'm just barely under that, so I guess we'd be all right. If
And
I
with
had,
Yeah, and with this new magnet, before our table weight was 300 pounds.
Oh, really?
Then
Well,
there's a
that
lot
would've
of
been touch
people.
and go, yeah.
Yeah, there's a lot of people that are over 300 pounds. So now we're able to offer that service here for them, where they used to have to go somewhere else, or they'd have what they call an open MRI. And there's a big difference in the images from an open MRI and from a full-strength 1.5 magnet that we have. Patients that couldn't fit into this machine before only had the option of going to an open MRI, low field strength magnet. So it only has a quarter of the strength of the high field strength magnets, so the images aren't at the same quality, so they had a less optimal exam.
We're talking about things that 30 or 40 years ago were only dreamed of, aren't we?
Yes, it's
I
MRI
don't
is
know when the CAT scan was first,
1970s is when I believe CAT scans were in use, but it used to take so long to get the images. I know that I've read where one image 1 hour, it used to take a long time, and now we get 16 images in a second. So there's a big
do you
difference.
really?
Yes.
Isn't that unbelievable?
Yes. And things have changed. MRI came about in the late 80s and 90s, so it's a pretty new technology, but it's rapidly advancing.
We had the good fortune of viewing a bone scan density machine on one of our other trips. We found that utterly fascinating.
Yes.
That we could scan bone density. People with a propensity for osteoporosis get their bones checked. It happened to my wife. She didn't have osteoporosis, but the doctor says since it's in your family, take this little Fosamax pill every day,
Right.
and your bones will be great.
Yes, we have a DEXA scanner here for the bone density scans, and that's done up at the plaza, at outpatient setting for those people, and we offer that Monday through Saturday for individuals.
And you wonder why people are living healthier, longer lives. Huh?
They're testing for everything now. You could do a test for osteoporosis now. We have a test now in CAT scan where we call it cardiac scoring, and we could, from a scan, determine what your chances are for a heart attack are. So imaging and technology is changing so rapidly. It's an exciting time right now.
Can we tell people what happens to the images that this machine takes? Where do they go
Sure.
and how do you read them?
Sure.
Okay. All right, we're on. Who are you, Miss Victim?
I am Jen. I'm one of the X-ray students at the radiology school here.
Oh, that's great. Where are you from, Jen?
I'm from Peru, from here.
Really? From the Great North Country?
Oh, yes.
How did you get hooked up with this group?
Just lucky.
Just lucky, I guess. Isn't that the stock answer? Have you wanted to do this kind of thing for a long time? Or?
Oh, I wouldn't really say that. Just kind of decided it, and then now I'm here and I like it, and this is what I want to do.
Oh, that's wonderful. We're going to see you through the window, I bet you, going through the machine, right? Have you done that before?
Yes.
Oh, you have?
Yes.
No surprises for you today.
Whatsoever.
All right, let's do that. All right, she's passed through and on her way. Liza, you want to give us a play-by-play?
Sure. Our two technologists that are working today are Joe Ashline and Heather Duquette. Our technologists here are credentialed where they have their registries in radiology, and plus Heather has her registry in MRI, so she went above and beyond a little bit. And she has an additional registry in MRI, and Joe is going to be taking his probably this year. And we have that in CAT scan too. Our technologists are all taking, it's nothing required by the state or nationwide, just the technologists want to take that extra step and prove that they're qualified above and beyond.
Now, explain how you're able to monitor here. I see them hooking up a cuff and a few other things here.
They're going to put EKG and they're going to monitor blood pressure on her O2 saturations. They're going to leave this monitored here, and they have a separate monitor they're going to have out here where they're scanning. Sometimes if it's a patient, most of the times when we give our sedation, minimal sedation here at the hospital, a nurse is involved also. And we'll get the nurse in here too, and she could explain that procedure a little bit. But we're lucky in radiology, we have nursing staff here. They're here Monday through Saturday throughout when we're scanning these patients. So if we have any problems, a nurse is here.
Is this machine in use a lot during the course of every
It
day?
is. We use this machine Monday through Saturday. 7 a.m. is our first patient, and our last patient's at 10 p.m. And we even
I guess
scan-
that answers
Yeah.
my question.
And we're even scanning on Sundays, 7 a.m. until 3 p.m. on Sundays.
Oh, wow.
We want to make sure there's a demand for MRIs. We don't want patients to wait. Nobody wants to wait, so we want to
There
provide
she
the
goes.
service. So we're putting her in. We have a monitor. We're monitoring her, and also now we're able to offer the patients if they have a CD they want to listen to or music they prefer.
Oh, really? Your
We have
favorite music?
Yes, we have the best sound system now, so now they can listen to something to make them comfortable and relaxed.
Little Enya going in there?
Yes. So now they're able to relax. We're able to communicate with them. We can interrupt the music and tell them the set's going to start and how long it's going to be. But this scanner is a lot faster than our other one. So scans now, we used to have some sequences that ran sometimes 14 minutes. And now we have sequences that are 3 minutes, 4 minutes. It's a little bit nicer for the patients. We're able to do the scans faster and get the patient in and out faster.
This includes senior citizens, young people, children?
Yes, everybody. Everybody, from 1 year old or younger even, all the way up to patients in their 90s and 100s we do. It's age range is a lot with the scans that we
Now,
do.
when did this particular machine get here?
In October. It came in late October, and then we went through some training. It took a little bit of training before we started doing some patients, and then we started getting patients in November.
September 11th. And Todd was telling us about what happened when the magnet was supposed to arrive in New York City. Do you know that story?
Yes, I heard it delayed our installation greatly because we had our magnet had to come from overseas. As soon as this happened, September 11th, it postponed the delivery of our magnet, so we had to wait.
Well, you can imagine
Yes.
what it was like without that magnet there
Yes.
on 9/11 and trying to get something into New York City and back up to Plattsburgh.
We
You
were
could forget that for a while.
Right. We understood everything, and we kind of moved forward. We had a lot of going on with our new CAT scan machine, so we directed our attention there until we could get the magnet over here. But we had a temporary magnet placed here at CVPH that we rented because we wanted to make sure we always provided the service. So we had a backup magnet here during that time.
So how big a total staff do you have for imaging all told, do you know?
Between CAT scan and MRI, we have about 14 technologists that work.
Wow.
But we provide a lot of hours of service, so that's why we have a lot. People, they all work full-time hours.
And most of the training is done right here?
Most of the training's done here. There's a lot of workshops that the technologists go to continue in their education and make sure we stay on top of the applications as they change. But a lot of the training is on-site. Just you have to do the exams, learn how to do them. The radiologists help us a lot in the training also.
That must be terrific. All right. Is she staying in this? Does she stay right there for the entire operation?
Yes, she
now?
does. And we could actually run a sequence so you could hear
That
what it
would be
sounds like.
wonderful. We'd
okay?
love to.
I'll let Joe and Heather take over. I'll let them take over talking.
Ooh, okay. We'll sneak around. All right, we're doing it. Who wants to tell me what's happening?
Oh,
Joe, right? What's
Yes.
the last name?
Ashline.
Oh, Joe. Another Ashline heard from. All right. Calvin wants to know what the smokestack is on the top. Does anybody know?
Yes, that's the exhaust for the helium, and the helium has liquid helium in it to cool the magnet as it's running.
Imagine that would get a little warm, wouldn't it? Huh?
Mm-hmm. Yeah, very. So that is the exhaust, so that none of of course, none of the gas escapes into the room.
Makes perfect sense to me. All right, what are we doing here?
Heather's just got done typing in the patient. Of course, before we start every patient, we have to put in their information, their name, date of birth, what exam we're doing, the diagnosis, just additional information that gets put onto the film so that the radiologist has that also to look at, and it documents for the films. And then she goes into an area where we can pick protocols from, and from there she sets up what we call localizers, and what that does, it takes where the patient is and it will run a couple quick sequences to localize that body part, and then Heather will have a couple different angles of the body of that part to set up pictures off of.
Oh, and you can communicate too, Heather.
Oh,
Huh?
yes.
That's cool. What's your last name, Heather?
Duquette?
Well, Heather, we're glad to meet you. Was this very confusing to you the first time you sat here?
Yeah, actually. For MRI itself, it takes a while to get used to the sequences and basically what the images should look like. I think filming is more of the confusing thing than the actual scanning itself, is to just get used to what each image should look like.
Are we looking at images now in the corner?
Yeah, actually. This is just coming up for us. It's basically okay that this is what the area we want to scan and what we want to look at. We just no, her knee.
We didn't pretend we knew anything when we came in here. Elbow, knee.
I know, I just wanted to know if she knew.
We know it was one joint or the other, huh?
If you don't, I can tell you it's an elbow, but
You can be very, very specific in what you want to look at, can't you?
yeah, actually, you can look at any part of the body really with it. With all the different coils that we have too, we have quite a few more coils than we used to have, so you get to get a better detail on body parts. As far as joint wrists, we got a new wrist coil where we didn't have that before. You used to have to use different coils to try to get the part where they weren't actually made for that anatomy that we were doing, but now we get better detail, I'd say, with the newer coils.
That's terrific. I hope
So that's what they get to hear.
they hear those
Magnified.
buzzing.
Well,
Oh, I
we
see.
give them the headphones, so they do, believe it or not, help out a lot more than the earplugs used to.
Yeah, I heard a clicking sound before that sounded almost like a clock. I don't know what that was.
It's just tuning to the patient, the
Okay.
machine going through its regular quirks. We'll try to do a quicker set anyway.
It's truly amazing. I mean, to me, never having seen one, it's absolutely amazing.
Never? You never?
Those are the localizers that I told you that we set up and run off of, which gives us 3 different looks at the body part, allowing us to set the slices up exactly where they need to be.
And actually, I don't know if you could see this set on our old machine. It used to, if I remember correctly, it was 7 minutes and 36 seconds, and it takes 3 minutes and 29 seconds now. It's the same exact set of pictures
Half the time.
half the
And
time.
half the time, that's absolutely amazing.
Yeah.
Now, how many pictures might you want to take? I guess it would depend on what you're looking for, huh?
Yeah, it varies. Spine, for any spine part, because there's obviously not as much coverage that you're looking for. The average is about, 40? I'd say about 40 images. Per sequence on like a knee or any other thing, minimum is probably 17 to 23 slices per sequence that we run, so it can vary very great. I mean, alone here you can see, what is it, 40? About 52 images for a knee when we're done. Sometimes if they had injury or any other pathology that we're looking for, we might do extra sets, so 50 to 70 images.
So all of this stuff is then held in the computer and printed out if you wanted to? You can send it to somewhere else from here, or?
Yes, there is a workstation in where the radiologist sits to read the films, and he can pull them up on the monitor right there. We can also send them over to CAT scan, where there's also another workstation set up in case we need, the radiologist happens to be over there, or a different one is on that we need to send it to. So yeah, we have the capability of sending it between our CT units and here, and also we film it up and put it on hard copy.
I see. You wouldn't necessarily analyzing the pictures from here, huh?
Oh, no. That's, as far as that goes, it's left for the radiologist to do.
Okay. That's kind of neat. What are these numbers up here?
That's just the temperatures, actually, for the machine, saying that everything is running right, that our pumps upstairs are running.
I guess everything has to be monitored. I don't know, the machines ever break down?
Not very often. We have an on-site engineer most of the time who's here 3 to 4 days a week. That's assigned basically to our hospital. He covers other areas too, but this is his main place. So, you know, occasionally we may have a minor thing, but he's usually right here to fix it, and we have very minimal downtime.
I can see where there wouldn't be any claustrophobia attached. I might even take a little nap if I were in there for 10 or 12 minutes.
Yes, this one's been a lot nicer for the patients. We used to bring in an open magnet to do our claustrophobic patients, and so far we've had such great success with this one, we've had no need for it. So we discontinued bringing it in.
I'm sure it's hard for many of our viewers to understand how powerful that magnet is. But what you see is a very big magnet inside that enclosure.
Yes, very large. It could take anything from a chain to a chair to anything of any size that if it was metal or steel is brought into that room, it will literally pick it off the ground and swing it through the air right into the magnet.
And yet we noticed the metal on the machine in there is not affected, so it must be not a magnetic metal, huh? It must be
Yes,
aluminum or-
right. Most is non, or is it made out of like a titanium or something that's non-magnetic?
That's fine. Well, we've learned a lot so far. We can take another step. Any questions, Calvin?
Yeah, I'm just wondering where these people got their training to get to work here.
Yeah. Where were you trained, Heather?
Right here at the
Right here,
hospital,
yeah.
Just came from X-ray. They opened a position to train in MRI and applied for it.
Oh, cool. You too, Joe?
Yep, same. Did the X-ray school right here at the hospital, and then had the opportunity to train in CT, and then from CT to here.
And you've been here how long, did you say?
About 7 years.
Wow. There's so much to learn. It boggles my mind. I can't imagine how people could learn this many things. But you do. Oh, look at here. A whole group of the images.
Images, yeah. So basically, we're starting at the top of the knee and going down, looking through.
Like these are slices, in effect, slices, right, Heather?
Right, yeah, there are slices, like I said, coming from head to foot. That's how you're looking down, going through the knee. We also do images in a routine exam. We would go from head to foot, right to left, and front to back. So you get to view the anatomy in three different planes.
And can these images be turned on this machine, or is that some other machine? I mean, if you want to look from another angle,
Yeah, you can scan in any angle that you want.
or you can.
Yeah, you can change it to any oblique plane. Pretty much, it allows you to scan virtually anything in any position.
Well, I'll tell you, it looks like a pretty darn healthy knee to me. How about you, Calvin?
I don't see anything wrong with it
I
myself,
see
Gordy.
nothing wrong with that knee.
I've been looking closer. I don't see anything.
I love it. Thank you so much. You both have done a great job.
Thanks.
Thanks, Joe.
Thank you.
All right, next step. We took a right-hand turn and walked through a door. Liza, where are we now?
We're where the radiologist who reads the MRI images sits. He's able to view them on monitors that we have here, and he's also able to view them from film. And we put some images on film for you to take away from the flicker from the monitors. So he'll view those with you, and this was all set up. We're getting ready for PACS, which is Patient Archive Communication System. And what that means
Don't
is,
you love 'em?
yeah, we're getting ready to transmit all these images digitally. And eventually, hopefully within the end of the year, physicians in their office will be able to just email their patients' exams to them.
Oh,
So that's where we're going. The technology's there now, so we're hoping if Dr. Stinger's not right here to read an MRI, but he's sitting in CAT scan, we could transmit those images, transfer him over to CAT scan, so he doesn't have to get up and physically come over here. So our goal is to make it a lot easier for the radiologists and for ordering physicians.
Oh, that's wonderful. All right, let's move over. Doctor, what's your name again?
Kurt Snyder.
Kurt Snyder. We're so pleased to meet you. You run this department.
That's correct.
And just explain to us what you've got here and what you want to show us.
Well, the first two films are actually from the CAT scanner, and these are just some examples just to show you what we can do with the newer machine. This is a a three-dimensional reconstruction of a patient with an elbow fracture. This is the proximal radius right about here in the elbow joint, and there's a fracture through that bone. With the new machine, we get very, very crisp, detailed, high-resolution images, and we can create these very complex models for the orthopedic surgeons to help them in their surgical planning. The other image we have here is just an example of what was a vascular study where we gave a single injection of the X-ray dye and then took images of the main artery that runs down your body, the aorta, and then it splits into the two iliac arteries. And as you can see, what we've done is we've taken the individual images and created a 3D model and stripped away all the other soft tissue structures and just left the bone and the blood vessel. And you can do any number of combinations. You can take the bones away and just leave soft tissues, or you can just have the vessels alone show up. Whatever makes it easiest for the surgeon in terms of surgical planning, we can pretty much do. Some of the MR images that I wanted to show you are just some examples of the different things that we can do now, some which we couldn't do before with the older technology. This is an example. This is a person's brain, and these are some slices through the upper part of the brain. These white areas on these images are abnormal areas that are due to small strokes, basically. And we see this sort of finding a lot in older people, and the question always is, are any of them new? Are they all old? Has anything changed? And these images down here, although they look a little bit fuzzy, are a very special type of image called diffusion weighted images. What these basically do is they enable us to distinguish between very acute strokes and strokes that have been there for quite some time. And if any of these were acute, they'd show up as very, very bright areas of abnormality on these images. That's important because a lot of times people, especially elderly people, come to the hospital and they're confused or they're just weak, and it's not really clear to the physicians taking care of them whether they've had another stroke or not. And very often in the past, there was no way of definitively telling that if it was a small stroke. Larger strokes would eventually show up in CAT scans several days later, but with this technique, we can image somebody within an hour after they have symptoms and know right away, is there a stroke or not? So that's a very valuable thing.
It's amazing.
These are just some pictures just to show examples of musculoskeletal work. This is examples of a person's knee. These are pictures taken from the side. This is the anterior cruciate ligament. This is the posterior cruciate ligament. This is a frontal picture. This black stripe here is the medial collateral ligament, and these little triangular densities there and there are the menisci in the knee, which get torn quite frequently. We can get very, very detailed look at the knee with this technique and tell physicians, are there ligamentous injuries, are there bony injuries, are there cartilage injuries, are there all three present, are there fractures, lots of detail that you can't get any other way. And so we do a lot of musculoskeletal work in the knee, the shoulder, the hip.
What's the most common knee injury among athletes, would you say?
Meniscal tears are the most common, and of the ligaments, the anterior cruciate ligament is the ligament that we most commonly see that is torn.
It's hard in some ways for knees to repair, but thank God for this kind of imaging and modern surgery. A lot of changes can be made now that couldn't be helped 50 years ago.
Oh, absolutely, absolutely. People who are athletic, the anterior cruciate ligament can be repaired, and the meniscal injuries, although a lot of them you can't repair, it is important to recognize them and go in and take care of them, because if you leave the knee damaged like that, they have a much higher risk of getting degenerative joint disease earlier in life than they would normally get it. So the orthopedic surgeons will oftentimes go in and cut out those damaged areas and repair as much as they can, and that is very beneficial. This image is not going to look like much of anything to your viewers, but it illustrates an important point. There's a particular diagnostic study that's been around for a long time called an ERCP, which stands for endoscopic retrograde cholangiopancreatogram, which is why everybody says ERCP, of course. That's a test where a gastroenterologist puts a long endoscope down through the mouth, down through the stomach, into the very first part of the intestine, and then they find this little opening where the ducts that drain the bile from the liver and the pancreatic enzymes from the pancreas empty into the small intestine. Now, there are several diseases that can cause blockages of those ducts, and it can make people very ill. It used to be that the only way to get really detailed looks at those bile ducts and pancreatic ducts was to do an ERCP. This machine that you just saw over here, the new MRI, we can actually get images of the bile duct and the pancreatic duct and tell whether or not there truly is an obstruction. Because if it's normal, then the gastroenterologist doesn't have to put the patient through that very involved procedure. And in this case, these white structures up here that are branching are the bile ducts, and they are indeed dilated in this case. And right here, it should be tapering down to a nice smooth end, and instead there's kind of a defect here, and there's actually a small tumor in this case that's causing the obstruction. So a very nice way we have now of demonstrating this type of disease. These are some vascular images. This is, again, the aorta, the main blood vessel that runs down through the abdomen. An area of much interest to a lot of physicians is whether or not there is disease of the renal arteries. Because if you have narrowing of one of those arteries to supply your kidneys, it can cause hypertension, and it can also ultimately cause renal failure. So we're doing a lot more of these types of images where we do what's called an MRA, which stands for MR angiography, where we inject some special contrast material and then can get these kind of images and show these renal arteries supplying the two kidneys and tell whether or not they're diseased or not. Now, in order to get this kind of image, what we used to have to do up until recently was to take a large needle and make a hole in the femoral artery down in the groin and thread a catheter back up through the abdomen and inject dye that way. And that would involve pretty much a day-long stay here at the hospital, and it was expensive and time-consuming. The patients had to lie afterwards for 4 or 5 hours until the artery sealed up, and so this is a real wonderful thing. This takes 20 minutes.
And the detail is amazing. I hope our viewers can get a good look at it, because that is incredible.
These are just some other examples of vascular work of other parts of the body that we study. These are the carotid vessels, the vessels that run up the neck to supply the brain, and they are frequently diseased in older folks. And it's important to recognize that because studies have shown that if there is significant stenosis, that surgical repair will significantly reduce your risk of stroke in the future. So we're doing an awful lot of these. Again, this was something we used to have to do with a catheter angiography, and there was a significant risk with that. Somewhere between 0.5% and 1% of people who underwent catheter angiography had a complication, and many of those complications were strokes. So this has been a very big advance for the North Country.
Well, we hear a lot of people talking about carotid arteries these days, and the operations to clean them out one at a time, generally, right?
That's correct.
So to be able to see what it looks like is wonderful for me.
Right, and our vascular surgeons locally are now generally operating on the basis of first an ultrasound to determine whether there is any disease present, and then the MRA after that. And they're not using catheter angiography anymore, hardly at all.
This is great revelation for us today. Kurt, let's find out a little bit more about your background. Where are you from?
I grew up about 30 miles from Burlington, over in Vermont, in a town called Underhill.
We've heard of Underhill many, many times. And you went to school where?
I went to college in Cambridge, Mass. at MIT, and then I came back home for medical school and went to UVM. And then I did radiology training, well, first a year of internal medicine and then radiology training down at St. Vincent's Hospital in Worcester, Mass.
And you've been in Plattsburgh how long?
Almost 12 years now.
Wow. I guess you found a home.
Yes, I certainly did, yeah.
But it's fun even for an expert such as yourself to watch technology improve like this.
Oh, absolutely. And actually, I do a number of things every day which didn't even exist when I was in training 12 years ago. It really, the field has changed dramatically, and the pace seems to keep accelerating. So it keeps us on our toes.
The bottom line is to help patients.
Oh, absolutely. And as I was saying, that there are a lot of things that have really made an enormous difference in the workup and evaluation and treatment of patients.
We haven't even begun to see everything yet. Dr. Kurt, thanks so much.
Oh, you're very welcome.
Have a great day.
Thanks.
Now, these aren't the people that were trying to make Dr. Kurt laugh in there, are they? No? We were interviewing him in there, and somebody was making faces at him in the side. Hi, who are you?
Lisa Jodwin, I'm the charge nurse in the radiology department.
Lisa, it's great to be here today. I'm sure you'd rather we were anywhere else but standing here. But it's nice to come here and just to see what happens on the inside, because a lot of people don't know you. They don't know what's in here, first of all, and they don't know there are nurses here. How long have there been nurses here?
I want to say back in about 1994, the nurses came to the radiology department. I think they only had one nurse back then. And then today, now we have 7 nurses staffing our department, and it's really a growing field to get into.
I'd like to ask everybody about who they are and where they're from. Are you a North Country lady?
Yes, born and raised here.
Where?
Plattsburgh.
Went to Plattsburgh schools? And
Yes, graduated from Plattsburgh High School and went to nursing school at Clinton Community.
Did you? That's wonderful. We're promoting that field these days. We need more nurses desperately.
Yep.
You know, it's been something that we're not going to get into much today, but our viewers are very much aware of the fact that there is a horrendous nursing shortage. And hopefully in a short period of time we'll be turning out lots of great new nurses. And I know the local nursing programs have worked very well, especially at Clinton. When did you graduate from Clinton?
1981.
Did you?
Yes.
Oh, let me see. You didn't go to school with my daughter Barbie, did you? Barbie Baker?
Yes, I did.
See? We're getting things together. Barbie's on Long Island now.
Is she?
Married with 2 kids and loves her job. She works at a hospital called Mather Memorial on Long Island, and she's been there for some time. She loves it, and she's a product of Clinton Community College.
That's right. There
When
were
I
only
heard your
about-
dates, I said, wait a minute.
Yeah.
You and Barbie are tracking along pretty good.
Yeah. We were 4 or 5 of us that were out of high school, directly into the program. So
Well, it's, she's had a very successful career in critical care. She chose critical care, and you chose this field, and obviously you're happy in it.
well, I've only been over in radiology for 3 years. I actually have been in critical care and worked in the operating room and the recovery room, and I worked in a doctor's office for about 2 or 3 years, and then I came back, and this was what was opened.
Uh-huh.
And
I just want our viewers to know that the nursing is a very noble profession. And it's important for young women who are watching this, who want to make a difference in their community, to say, yeah, we can do that. We can pause for a minute. Yeah. Everybody's got beepers in this day and age. You don't worry about things like that. Who are you?
Hi, my name's Lori Burnett, and I'm a nurse in radiology who also graduated from Clinton.
See, Lori, that was the one she's been trying to hide ever since Calvin walked in the room, trying to get behind everybody else.
Get behind everybody. I'm not a television kind of girl.
Oh, yes, you are. I can tell by that smile. So tell us a little bit about your life.
I graduated from Beacontown in 1984. I didn't go to nursing school right away. Didn't graduate from nursing school until 1990. It's a good profession, and it just opens up a lot of doors for a lot of people. A lot of different things. I didn't work in radiology right away either. I started out on the nursing floors, taking care of post-op patients, and then came down to radiology 2.5 years ago. Good place to work.
You know, this just goes to show you don't have to make a lifelong decision on what you're going to do when you're 12 years old. When I was a kid, boy, you were supposed to make up your mind to be a doctor or a fireman or a lawyer or, in my case, a radio announcer by the time you were a very small child. Nowadays, people change careers 3 or 4 times sometimes in their lifetime.
Well, I'm a nurse now. That's what I'll be. I don't see me going anywhere else, so. But I like nursing.
You know, we've met so many nice people over here. It's a bunch of good people in this medical center.
Good. This is a good facility. Lots of good people, lots of good nurses.
We talked to Todd Krampitz before, and we described it as a family, and it pretty much has to be, because you guys do some pretty intense things in the course of a day, and it doesn't help when when you can't stand each other. So it's pretty good to get along whenever possible.
We have a
right?
good group down here, the 7 of us. We have a good group.
At least you
get
have
along.
a sense of humor, and that's very important.
Oh, we have this is our humor.
I know you're Sally. What's your last name, Sally?
Harvey, and I graduated from Northeastern in 1986 and went
Three
into
schools represented so far.
What's her maiden name, though?
cast iron.
Oh, no, you're not related to
Oh
Calvin.
no, I'm one of them. Yeah.
No wonder he's been showing you a lot on television.
Don't say that, I'm going to blush here. And I went to Clinton Community and I graduated in 1988. And I didn't start my nursing career here first. I worked in a nursing home and then I went to Alice Hyde. Then I came back to Cvph and I worked on the floors for a few years. And then I went to IV therapy and specialized in IV therapy. And now I've been down here for 2.5 years and I love the nursing down here.
That's wonderful. Give me a clue about a few things that you do in the course of a day here.
Well, we prepare our patients for their diagnostic exams. We explain the procedures. We question them and go over a short history and physical. We start IVs. We do biopsies, sedation if they should happen to need it, for both CAT scan and MRIs. We do quite a bit.
You described your whole job, right, Lori?
Right.
There wasn't anything left for you to tell?
Nothing else for me to tell. Nope, Sally got it all.
Is everybody else we've talked to today has said this whole thing here is a learning experience almost every day.
It
You
is.
can't come into this every day with a closed mind, can you?
No. There's always something new here, new testing, new technology going on.
Do you guys have to go to regular trainings, or do you just kind of get it on the job here, or how does it work?
Pretty much on the job and in services for new equipment, new monitors, competencies to keep our skills up. So every day, yep.
Well, this is a perfect testimonial for Clinton Community College School of Nursing. And, you know, we've watched, I'm old, so I've watched the nursing program there since the very, very beginning. And Agnes, our good friend Agnes Pearl, is the icon of North Country nursing education. And you probably all know Agnes very, very well.
Sure do.
And had her in school and so on. I thank you so much for taking a couple of moments to do something that wasn't in your contract. But you're all such great sports, and I wish you all the very best with everything.
Thank
Thank you. Thank you.
You know, it just dawns on me, Liza, as we pass the X-ray department that we've been talking about this new technology, but X-rays are still used every day, many times every day.
Every day. We have an X-ray room in the emergency room. That's pretty new. It's only been here a couple of years. So patients before, if they were in the emergency room, they had to walk over here to radiology or be on a stretcher and get transported to the radiology department. Now they can have their X-rays right within the ER and stay right there. So we have a technologist that's there, scanned all through the shifts, that just does X-rays for the emergency department to help them get patients in and out faster.
You know, it's so great because most of our viewers, I'm sure, have never seen this equipment.
No.
So it's a great education and a revelation for them. Where have you brought us now?
We are in the CAT scan department here at the main hospital. This CAT scan machine is what we call the quad CT scanner. There are 4 detectors. So compared with our old CAT scan, it goes 4 times as fast. So it takes 16 slices per second. Our CAT scan machine that we have at the plaza takes 8 slices per second. But we have just a little bit of difference between the 2 scanners because we do a lot of the vascular imaging here at the main hospital where there's a lot of staff and the radiologists are here. So that's why we got a little bit faster scanner here at the hospital.
So the CT scan, the CAT scanner, is an entirely different technology from what we just saw with the MRI.
MRI uses a magnet and radio waves, and this uses the principles of X-rays and a computer and detector systems to get images for us. But the principle, the main physics behind it, there is an X-ray tube within this gantry. This is what we call a gantry. So same principles of X-ray, but just a little bit more on it.
Now, is it a low level of radiation compared with regular X-ray machine? Or?
Well, an X-ray takes a snapshot, like one image.
I see.
Where this is taking, if we do a CAT scan of your abdomen and pelvis, we could do probably 80 images or more, so there's a lot more images. But over the years, the FDA has gotten involved and radiation dosage is minimal. We have our on-site engineer. We have to do calibrations and testing daily and weekly and monthly to make sure that the radiation output this machine does is within limits and guidelines that are set by the FDA.
It's nice also, while we're looking at this equipment, to let our viewers know that CVPH Medical Center is right on the line. Technology. It has the latest of everything.
It does. We stay proficient in everything. We have always acquired the new technology that comes out. When we hear it's out there, if we don't have it, we try to offer it here. The hospital always looks into that. People don't want to leave the North Country. They want to stay here and have their testing done. And if we provide the service here, they stay here.
And I just want it known for the record that there were a lot more people here when we arrived than there are right now. They went in every direction, didn't they, huh?
They did. We have a lot of camera-shy individuals here, but they're great technologists, though.
Oh, I'm sure they are, and I can understand that. All right, so why would a person have a CAT scan and not an MRI?
CAT scan, it goes a lot faster. You don't have to go through the safety issues with it because everybody could have a CAT scan. There's also the cost difference. There is a difference in the cost between a CAT scan and an MRI. CAT scan shows some things more detailed, and MRI shows things. Certain tests show things more detailed than the other. So depending on the diagnosis or the history that's presented, one test could be better than the other. Patients come here, every car accident that there is that you hear about, they come here to CAT scan. We're able to scan them within 5 minutes. We could tell if it's their abdomen and pelvis, their belly. We can make sure that the liver's not lacerated. They come right here, and we're able to get an answer in 5 minutes. Where an MRI, because of that motion, you're in pain, it's hard to get accurate abdominal imaging. So CAT scan's a better test for traumas. And also when people have strokes, or patients have car accidents, again, we want to look at the brain CT only takes a minute. So we're able to get an answer what's going on in the patient's brain within minutes.
And in the case of trauma, you need to find out quickly. Somebody's got something going on inside, you need to know about it.
Right, and that's where CAT scan is a great tool for that because it is sometimes quicker than x-rays even. If they have a heart patient where they're having a hard time looking at their neck, we call it the C-spine, and there's 7 vertebrae within the C-spine. And a lot of times it's quicker to get the patient on the CAT scan table, scan the cervical spine instead of trying to get the x-rays through the hard area of the shoulders when there's like a lot of dense tissue there to go through. So the CAT scan's a lot faster and we're able to scan from head to toe very quickly.
Now, do you have the same kind of monitoring outside the room as you do for the MRI?
We're right here. We have monitoring equipment here because we do biopsy procedures here.
Ah.
Yeah, we're able to, if we have a CAT scan that's abnormal and we see a nodule or a mass, the patient can have it done here, where before a lot of times patients went to the OR and had that biopsy procedure done. Here a lot of times they just walk out with a Band-Aid. They're gone within 2 hours. The patient has a procedure, it takes about a half hour. If it's a lung nodule, they put a little needle within that nodule. Patient goes back to ambulatory care. We monitor them for about four hours just to make sure everything's going okay. If everything's going good, their vitals are good, they're breathing well, we're able to send them home. Whereas if they used to go to the OR, they used to have a procedure where they had to be cut open, chest tube when they came out. So it's a lot user-friendly here.
It certainly is. And, the ambulatory surgery was not even in the nomenclature not too many years ago.
Right.
And now we move them in and move them out, and people, because many of the surgeries are less intrusive, the imaging is less intrusive, they can repair and go home and get back to work and their families way, way quicker than ever before.
Yes, that's when managed care came about. They looked at cases and said, what can we do to make things go better for the patient? Patients want to get in and out of the hospital. Insurance companies want patients in and out of the hospital. Nobody wants to be here any longer than they have to. So through the years, procedures are done very accurately now because they've been looked at, tested, and regulated. So now a procedure is done a certain way that's the best.
Many, many years ago, and this is a good point I think to make, people were really frightened of hospitals because when you went to the hospital, it generally meant you had something terribly wrong with you. Babies weren't even born in hospitals, for goodness sake. And I had a very good friend whose name I certainly won't mention, who died about 40 years ago after telling me he had horrible emphysema. And he said, Gordy, if I ever have to go to the hospital, you don't even have to come and see me because I won't make it. And he was brought to the hospital when I was out of town, and he was so frightened, I believe to this moment that he was scared to death by coming to the hospital. Whole different ball game now. We have
Right.
beautiful, bright rooms with colorful borders
It
and
has changed.
smiling nurses and doctors and
Yes.
wow.
We did this X-ray room, this CAT scan room, used to be white walls, no pictures, and we changed it when we remodeled for the
It's
new
so
scanner.
cool.
People want to have a friendly atmosphere. They don't want to be reminded that they're in the hospital.
Well,
so
you
we
told
try-
me before about people undergoing the MRIs, listening to their favorite music.
Right.
Doctors operate listening to opera or rock and roll.
Right. They want to make it less hospital-like, less sterile. It used to be so cold and sterile, and the green colors, they're gone now. Everything's more friendly and calming colors now. And
Well,
everything.
it's kind of nice to see it from the inside because we could stand on the front lawn and talk about that all day, but seeing it from the inside makes it a lot easier and more palatable, I'm sure. And there are bound to be people who are watching this show who were told you have to go and have a CAT scan or you have to go and have an
Right.
MRI, and they wonder, oh my gosh,
get
what is it all
nervous.
about? Now you
Right.
know, folks. You like
Right.
it? Not bad.
And we actually do have the plaza, the CAT scan machine that's at the plaza. If you don't want to go near the hospital, when we take a trip up that way, there's a totally different atmosphere. You don't see any sick patients that are in the hallway. Your scheduled appointments also. You don't have the delays from the emergency room or from inpatient emergency exams. You have a scheduled appointment and it'll stay at that time. Before, it used to be one CT machine. If there was a trauma with 5 patients, your scan could be delayed by 3 hours or so.
Oh, boy.
So now there's a place at the plaza where people can have their CAT scans, get in and out. That way there's less anxiety and they're able to get out very quickly.
There are so many good reports about everything
Everybody loves
at
the
that
plaza.
part of the CVPH campus. Nice
Yes.
people, guaranteed a certain time that you're going to get in.
Right.
If you have to have a blood sampling or something done, it's amazing.
It is, and that's where I go. I have a little boy, and that's where I bring him for if he needs blood drawn, because you're in and out. It's very quickly, and the worst thing is if you have a youngster and you need to get blood drawn or x-rays, then you sit in the waiting room for an hour, and then it doesn't happen here. You go to the
Time
plaza.
to think about
Yeah.
it. You have time to think about it.
Right.
Yeah, that's great.
And actually, things are faster down here because now we have a second area where people go. So where you had to wait down here, there's no wait anymore because a lot of our outpatients are up there. So it's a win-win for here and for the plaza.
That's great. Have we seen almost everything here?
We could go over some images. I'll introduce you some text and CAT scan.
I
and
would
some
love
images
to.
down.
Let's do it.
Okay. One thing, do you have patients' names off that monitor?
Okay, we're on the outside looking in. Who have we got here?
This is Donna Jo Plummer. She's one of the staff technologists here. She is registered in CAT scan and MRI, so that's where I talked about the registries going above and beyond what's expected. So she went above and beyond in both areas and has 2 additional certificates.
Okay, can you live up to that introduction? I want to know.
It's a big one.
Donna Joe, where are you from?
From Dannemora.
Wow, Lion Mountain, Dannemora, northeastern Beekman Town. We got the whole North Country covered. So you are a North Country girl too.
Yes.
It's amazing to me how many people who work here are from here. I love it.
Went to school here.
Did you?
Right at Cvph.
That's terrific. You graduated from high school in?
You want the year?
No, not the year. Although she had to tell us. No, where? What school?
Saranac. Saranac Central.
Okay.
Yes.
See, I came here before the schools were even centralized, and there was a big argument as to where they were going to have the school, so they put it in Saranac. So you went to Saranac and you lived in Dannemora?
I moved to Dannemora after I graduated from high school. But I grew up in the West Plattsburgh, Morrisonville area.
Well, not very far from me, because I live right next to the fire station in Morrisonville.
Oh.
So you're not very far away. Did you ever think, well, maybe I'll move to Oshkosh or South Carolina? Or
No.
just decided, isn't that funny how people born and brought up in the North Country and decide to stay here, or they move away and wish they could come back.
Nowhere
I
else
know a
can,
lot of my kids are the same way.
yeah, nowhere else you get the benefits of the lake through the summer and skiing in the winter. It's a beautiful place to live.
All 4 seasons.
Yeah.
So that's what you really want, is the 4 seasons.
We may gripe from time to time when ice storms come and knock all of our trees down, but otherwise, yeah, it's a pretty darn good place to live, and we like to put that in most of our programs. So what do you do here?
In CAT scan, we do a little of everything. Any body part you want. It's very similar to the MRI unit. It's similar to slicing a patient up like a loaf of bread, and you get the axial image looking from the feet up. You can then take those images and put them together in a volume, and then slice them different directions so you can get other looks at the image from the one data set, which will save the amount of radiation to the patient and the length of time they're on the table. And by doing so, you can also change the window and level so that you see different types of tissue. You can look at the bone, such as on a trauma patient. One shot, you can do the whole body, and then you can turn around and look at them for soft tissue, for bone windows, to look at the lungs. And your patient is only on the table for a few minutes, but then you've got all the data set to take and do it any way you want.
Less hassle for the patient.
Much easier. Much shorter timing, too, for the physicians to get the answer they need.
You know, I'm just looking in there, and the size of this unit is not that much different from the MRI unit, is it?
No. This one here is about 3 feet, and the MRI unit is only about 5. So there really isn't much difference.
So if you can do one,
You can do the other. Yeah. And with the shortened time frames in both areas, it's very short that even if you were doing a head where your head would be right in the middle, you're not in there that long at all. And we can talk to the patient continuously in both units.
I noticed that in the other one.
Yes.
The other one makes a little more noises, though, doesn't it?
Yes, you don't hear anything with this one. You could tell the machine is on, but it's just it's a minimal humming noise, you could say it, but there's not the noise, the pounding noise or jackhammering.
It's not disquieting at all. At
No.
least it doesn't seem to be that way. No. Does your job keep you right here all the time?
I rotate between both areas.
Oh, you do?
Yeah, I do both. And that was why I got the degrees in both.
So
for
you
the
got to learn
registries.
all that good stuff.
Yes.
Huh? We've talked about education before, and it's not, you know, it requires a kind of a commitment if you're going to do this job. I mean, it's
ongoing.
and it's ongoing. That's another great point we made. People say they're learning every day when they come to work.
Yes. And you learn from your coworkers. Somebody may do something the night before, and when you come in the next day, say, hey, I tried this, and this really worked good. You might want to try it and see what you think. And that's how you also continue your education, is feeding off from each other and giving each other tips and hints.
I think that's a great idea. And I also think we ought to mention the names of a few of the other chicken people that didn't want to get in front of our...
We have Brenda Bedard that was working here today that ran out, and Aaron Blaze, who's here today.
So the friends can hassle
Yes, Karen Rombach. At our off-site at the plaza, we have Rob Remchuk working and Allie Kay working. And you met Joe and Heather over in MRI, but Nick DeSorga just came in too. So we have a lot of people that work here between CT and MRI. And all the technologists that are here also, another requirement to be a radiologic technologist is we're the only governing body that has to do continuing education. We actually have to hold 24 continuing education every 2 years.
You've got to be kidding.
Right, so you could do it through college courses, we could do it through, we have to go away for seminars. The hospital tries to do a couple seminars here, but we always have to stay up on our education because the technology is changing fast, and no other professionals have to do that.
I really think we ought to tell the new president that you both need to double your salaries, don't you?
Now I'm really starting to like you a lot more.
I spend a lot of time in this medical center as part of the foundation, and I enjoy what I see here. And it especially pleases Calvin and I to come back and look at all the new things. The technology just astounds us and amazes us because we know what the bottom line is, helping people.
Right, that's what it is, and everybody enjoys what they do here. And that's why we got into this field to begin with. If you don't like people, you're not usually working in a hospital, and there's a caring, compassionate that's here, and I see it in everybody that works here. They actually treat every patient like it's their mother or somebody that they care about.
I think that's a good point. I mean, you know, it's easy for us to laugh and have fun, but there's a serious side to this, and you make that commitment to want to help other people. And when you go home at night, you know you did good, don't you?
Most of the time.
Yeah.
There's sometimes that you go home and think, oh, maybe could have been better. But some of that is just the emotional toll of the job. You see some people come through and they're doing great, and here in an MR versus some of the other modalities, you see the same people sometimes over and over again, and you have those really nice high days where you see somebody's doing really good and they're getting better. And every now and then you get that unfortunate one where you've made some type of relationship with the patient, and maybe it's not going quite so good that day.
It's called empathy.
Yes.
And even though it's trying on us sometimes, we wouldn't want to be without it.
No.
That's great. You guys are both terrific. We're going to take a trip pretty soon, you know.
Yes, we're going to go to the plaza, let people know about the outpatient facility that we have. We'll look at the R2 image checker for mammography and the new stereotactic breast biopsy machine that's up there. And if we want to take a peek at the CAT scan machine that exists up there, we could do that.
All right, let's do it. But before we go, we're going to take a little trip. Tell us what's happening.
We're going to talk about this one's virtual bronchoscopy. There's also virtual colonoscopy, and that's where, without the use of going up to have a procedure upstairs, when people call it the garden hose for the colonoscopies upstairs, this is a non-invasive procedure where we take images through the patient's body, and this machine is able, the data and software on here is able to manipulate it, and we're able to look inside. So we're going to look inside the trachea of this patient and go down, or if it was the person's colon, the patient's colon, we take a trip inside the colon to look for polyps or masses.
It's amazing. And if this looks familiar to our viewers, they've seen it on the commercial, haven't they?
Yes, it's very impressive. It's almost like playing a video game, it seems. But this is a patient. This is an image where we're just looking on the side where we're going to do our path. Just wait 1 second. Of course, it's not going to go.
Isn't that always the way when you want to hit one button and it doesn't work? Oh, boy.
There we
It
go.
goes.
They had the pause button on.
Oh.
But this is telling me, you can see like a little F in here. I'm taking a voyage down through the patient's trachea, and we're going towards the feet. And then we're going to come where it divides.
Is this somebody's real trachea, or is this?
Yes, it is. This is somebody. This is a patient.
Wow.
And what they looked for, sometimes patients, a lot of times they go to the OR and they go through a bronchoscopy where they swallow the tube. It gives them, the physician, another look at it before they take that step. If they want to make sure there is a mass there, they can look here and say where the mass is and do their treatment planning a little bit better, know exactly where they need to go. Because right now with CAT scan or an MRI, you're not getting that inside look. So this gives them an inside look of what's going on. And the same would be for the colon. We'd be able to see if there was a patient could go through this procedure, see if there's any polyps. If there's no polyps, there's nothing to have the colonoscopy done for to get a biopsy. But if we do the colonoscopy, see the polyp sitting there or something that doesn't look right, they could have the colonoscopy and get a biopsy done at that time. But it's just more imaging.
I bet you and looking at imaging like this, you could tell if a person was a long-time smoker.
Yes, they would be able to see like the lining that is within the trachea. We'd be able to see differences in it. Yes, the radiologist would look at this, and he's the expert on it, but he'd be able to tell more about the images. Yes.
You know, not too many years ago, this was only in our dreams. This was computer animation years ago. Calvin mentioned the Fantastic Voyages. Now it's for real.
It is, and it's unbelievable. Like next year or the year after, the technology will be even more than this.
And now, in the last few months, we have seen pictures on television of miniature television cameras the size of a capsule that you can swallow.
I know, I saw that too. I saw
Isn't
that where they
that
got
amazing?
an inside look. The technology is unbelievable, and we now have where all these images we take, we transmit to the workstation, but we're also able to transmit these images to the radiologist's home. So that's how we're able to have 24/7 coverage. 24 hours a day, we have a professional radiologist looking at these images, and we're able to network these images to their house, and they're able to read them and transmit results back. So that way, there's no more of the doctor that lives a half hour away waiting for him to come in to look. Right now, as soon as the scan is done, we transmit the images and we get a report back really fast.
A far cry, folks, of when Physicians Hospital opened its doors here 75 years ago. You've taken me halfway across town on this adventure, Liza. Where are we?
We're at the plaza that we always brag about. We just wanted to show to the people out there how easy access it is and how quickly it is to get to where the CAT scan machine is, where you don't have to go through the whole hospital with this. It's just a little walk, and we'll take you down that walk.
Let's take a little walk and talk about it as we go. We were here when the building first opened, before anything was happening, and Todd was showing us around saying, I think this is what's going to be in here and what's going to be in there.
We're pretty full here now. We have the CAT scan machine now, the BMD machine, that bone test is up here. We have x-ray up here now, mammography. It's a very busy place now. It's pretty full. And ambulatory care at the center that's here for outpatient surgeries is here.
very, very successful, and
Yes.
nothing but raves from people who come
Right,
here.
because it's a very, parking is easy, every parking spot is close. There's no walking far out or not knowing where to park. Like at the hospital, a lot of people park at the wrong side of the building and have to take a walk. Here, no matter where you park, you're going to get to where you need to be fast.
Okay.
Yeah, so CAT scan, we came in at 85, there's a big sign that says CAT scan.
Okay, and
then we have
another big
CAT
sign
scan
here,
and
and
CAT
another
scan.
sign here, okay.
And this hallway,
Yep.
this hallway's for CAT scan.
Unlike what you learned in kindergarten, CAT is not CAT though.
Yeah.
No,
CT
CT.
scan, right.
And this is our technologist here. This is Allie Kay. She's one of the technologists up here.
Hi, Addie Kay, how are you?
Good, how are you?
We're terrific. Did you know we were coming?
No, I did not.
Oh, look how we're ready.
That's why we're so glad we came in to shock you.
I gave warning earlier today. I should have passed
I
on.
thought if you were coming, it'd be before noon or 1.
See, you were just hoping we'd be out of here and you wouldn't get your picture on TV, but we're pleased to meet you. Where are you from?
I'm from Cvph.
Another country heard from. We've heard from almost every town in Clinton County so far today. You grew up in Keysville?
No, I'm originally from Antwerp, outside of
I
Watertown.
know where Antwerp is from. I know
You do?
almost every place in New York State. I lived in Carthage for a while.
Oh, yep, my husband's from there.
See, I know lots of people from Lowville.
Yeah.
Met somebody this week again from Lowville. Antwerp's a good place to be from.
Yeah.
Then you
yeah.
moved to
I liked
Keysville.
it. Actually, we went to Vermont first and then here.
Oh, well, we have to get the whole
I've been
tour,
all
you
over.
know.
Yeah.
So did you go to school in Antwerp or
High school is
Yeah.
Indian River, which is
Indian
outside
River?
of Antwerp. Yep.
Indian River? Now it's
Yep.
Indian River Central, right?
Yep. Yep, because of Fort Drum. And then I went to Potsdam State for 2
Did you?
years. Yep. And then I went to Champlain College for radiology. And then I ended up here in Plattsburgh.
Isn't it amazing where our trips take us in life, huh?
Mm-hmm.
So how long have you worked up here?
It's going to be 5 years this summer that I've been at Cvph.
Oh, that's terrific. Do you
Yeah.
like your job up here?
Yeah, I love it.
Good.
Yep, I really enjoy CAT scan.
What do you do in the course of a day?
Oh, let's see.
Wow.
A lot.
That's
We
breakfast.
do. We do quite a bit. Anything from, well, like a day like today, I work here at the plaza with outpatients. So we do a lot of oncology patients or routine outpatient exams. And then a day at the hospital could be, walking into emergency. Well, like last night, I was on call, so I did emergency patients overnight in the ER. And then at the hospital, you have outpatient biopsies, inpatients, and then we do some routine outpatients there too. But anything in CAT scan. We do anything from head CTs to abdomen, pelvis, radiation treatment planning. We do a lot. Emergency trauma codes, we scan a lot.
Allie was
We
here
do
all
everything.
night.
Yeah.
Oh, come on.
Yeah.
She the night last night. She's
Oh.
back here today working.
It's almost time for bed, isn't it?
Yeah, I'm getting a little groggy. I gotta get some coffee.
I'd like a cup too. Thanks so much for
Yep.
saying hi to us today.
Oh, no problem. It's
Good
nice
luck with
meeting
your
you.
Career.
Thank you.
See that? The most charming people in the world.
We surprised her
I
also.
love it.
But the benefit of the plaza, like this is where the patients come in, and I'm not sure if we have a patient, so we'll just stay.
Yeah.
But this is where the patient comes in. We have a receptionist right here. And then if they need to have an IV lock, our nurse preps them right here in this room. And this is where the scanner is. So everything is right here in this hallway.
Oh, isn't
So
it?
there's no walking around. We're able to register them right here. We're able to do their paperwork up right here, and they don't have to travel anywhere else.
So what's an IV lock?
IV lock is where we, sometimes exams that we do in CAT scan, we need what we call IV contrast because we want to highlight the organs
Oh,
or
I
the
see.
vascular
Okay.
system. So we put a little IV in their arm, and that way our nurse comes in and we're able to give them the contrast we need. There are a lot of things. But it's the same thing from the hospital. This is the CAT scan.
Okay. Oh, this looks familiar now. Did I get the cord under the door? All right, we're in.
And this is the CAT scan machine here. It looks exactly the same as the one at the hospital. They're both brand new, so that's why they look a lot alike. And it's just an outpatient setting up here. They come in, they get their scan, they're done, and they're able to leave. It goes very fast up here.
Just absolutely terrific. So we got both ends of town covered.
Yes, we do.
You know you've arrived when you have a campus and you have things that aren't directly connected with the medical center. And we made the rounds of that campus a few years ago, and it's great to come back for updates.
It is. Things are changing so rapidly. Like this just came in this summer, just got installed this summer, so things have been different. It'll change every time. It's going to change. If you came back in 6 months, there'll be something different up here at the plaza also.
So do the people go back and forth between the hospital and here? And
The
back?
technologists do, the nursing staff does. Everybody, we want to keep them proficient in the different areas because some things might run a little differently up here than they do at the hospital. So we try to give everybody a turn and move around a little bit. That way at the hospital there's a lot of traumas and codes and it's the pace is a little bit faster. Here it's a little bit more relaxed. It's an outpatient setting. You don't have the lifts that you have at the hospital where you have to help patients as much. This is where patients usually walk in and walk out.
And if you're lucky, Gordy, you can work both places in the same day. You can work.
That happens
Like that
also.
poor young lady that we just saw. Yeah, she was ready for a nap.
We have a lot of multi-modality technologists. That's where they took the initiative, did training in both CAT scan and MRI. And so if we have staff that calls in sick in MRI, we're able to use sometimes the staff from CAT scan to cover and vice versa. So it's great that we have staff that's willing to do that.
Nice to be young with that kind of energy to it. All right, Liza, what's next?
Okay, we're going to head over to mammography.
All right.
Okay.
All right, this is something we've heard a lot about, and I want to learn a lot more. Robin, what's your last name?
McLean,
We're so glad to meet you. Again, I have to ask everybody, where are you from?
Peru.
Wait a minute, that's two from Peru so far today. Always in Peru? You've always lived there?
No, I used to live in El Sabo.
Okay, so you went back and forth.
Yep.
Okay. So now you're here, and this is the R2 image checker that people have heard so much about on television, in the newspaper. What the heck is it?
What it does is it's just kind of a second look for the doctors so they can have a second look at the mammogram. It's something else that reads the mammogram. Mind you, without the R2, you couldn't have just the R2. You have to have the doctor too because the doctor decides what's important and what's not important on the film. It could be something that's been there for many years and it marks it, but it's something that the patient's had for many years. So what we do is we have the 4 routine pictures that we do and we run them in a special order. So when we run them through the machine, they come up for the doctor and it picks up the scanner so it can show the doctor what number it is. It only shows the number. It doesn't show names. That way we can reuse the pictures. And they come up, all 4 pictures come up, and then it's transferred from here into the reading room so the doctor can look at the films after he's read the mammogram. So what the doctors do is they read the mammogram and then look over at the screen to see what the image checker has marked.
Why is the image checker better than it used to be when it wasn't here?
It's just kind of a second look at. It's not that it's a second look at things. It's supposed to catch things earlier.
That's important.
Yes, it is. Most definitely. Most definitely.
No, it's only been here a relatively short time.
Yes. Yes, we just got it in November. I think when it was.
Yeah,
We just got it in
I think
November.
It was in November.
Yes, it was.
Working with the foundation and various other organizations trying to raise money to pay for it.
Yes.
And it's really nice, as Liza said, to see people with the R2 pins on.
Yep,
and,
definitely.
Around town because we one of our goals in doing this program and one of the goals at Cvph in general is to let people know that this is their medical center and that people are involved in this medical center.
Yes, very involved. It's growing every day.
So how long have you been up here?
I've been up here for 2.5 years.
Okay, and are we looking at images that you put in there?
Yep, these are images. Actually, the first image has just went through and came up on the screen. And then as it picks up the other images, it'll go through. As it picks up the images, once the image comes on the screen, it becomes a blue box. And once it's all set for the doctor to look at, a green box goes around it. So that's when we know the doctors can pull it up on their screen.
And they get a larger view
They
than
get a
we're
larger
here?
view. Yep, they have a larger screen and they get a larger view of it.
Now, does this machine preserve the images, or do you just put them through here and then they come back out?
Yep, you put them through, comes back out, and then it goes into there for the doctors.
All the images stay on file?
Yeah.
Yeah, okay.
The image checker keeps about 1,000 images.
Oh, my goodness,
And then
really?
we just you can override them after that.
And it's touch screen technology.
Yes.
And McDonald's thought they were a step ahead. Oh, isn't that neat? You can almost hear it work in there. What a great idea.
Yes, it is.
This is such a bright, fresh, clean place with bright, fresh, clean faces. It's so nice to meet all. We've met dozens of people here today, and everybody, unless they're all wonderful actors, enjoy what they do. I'm sure it's at times trying, but it's a good profession.
Yes, it is.
That's
Yes, it
great.
is.
That's wonderful. Well, thank you so much for
You're
showing it to us. That's terrific. What a team. What an absolutely wonderful team. What else did we miss?
We're going to meet with Dr. DeLise.
Okay.
He's a radiologist up here today reading the mammograms today.
Let's do it. All right. I love dark rooms anyway. Dr. DeLise, how are you?
Very good, Gordy.
Great
Thank
to
you.
see you again after a couple of years. What have we got here?
Well, Gordy, we have some mammograms, and I know you're primarily here to see the R2 checker and how it fits into what we do, and that's what I'd like to try to explain this afternoon. I would like, however, to take a minute to thank the people of the North Country for their generosity. The R2 reader, as you know, is a gift from the people of the North Country to the women of the North Country and the Medical Center.
Thank goodness we're able to get the word out and let people know how important this kind of technology is for you.
Absolutely, Gordy.
And for the people who
benefit from it.
Here, sure.
Absolutely. It is like computers elsewhere in our life. We are using them everywhere in our life to help us in what we do. And that's why this is specifically called computer-aided detection.
Aha.
And what we do primarily at the Women's Imaging Center is screening mammography. Now, screening means looking for occult disease in an otherwise healthy population, whether you're looking for prostate cancer, skin cancer, colon cancer. That's in general what it means. And in order for screening programs to be successful, they should be affordable, they should be accessible, the modality that you're using should be creditable, and it should be fairly simple. And fortunately, mammography, through the efforts, nationwide efforts, has fit those criteria. And what we're doing when we're doing mammograms is we're looking for suspicious findings that may turn out to be cancer. Cancer often does not jump out at you on the mammogram. The findings are relatively subtle, and it's a little bit like finding Waldo, if you will. And the R2 reader helps us with that. And when we're reading mammograms looking for malignancy, we're basically looking for about 4 things to help us out. We're looking for masses, we're looking for densities, we're looking for calcifications, and we're looking for what we call architectural distortion. And the R2 reader does that as well. That's what it's programmed to do. As you saw, the first part of the machine is where the mammograms are fed in. And in that machine is a database of 3,000 positive mammograms. There are 3,000, the findings on 3,000 mammograms previously done on other patients around the country that had cancers. And then it compares that database to the mammogram being put through. Okay? And it looks for these 4 categories of suspicious findings. Okay, and then it marks those on the screen, and I'll show you that in a second, to bring our attention to those areas. And what we do as radiologists in reading mammograms, and this is a reader made specifically for looking at mammograms, we load up the current mammogram on the bottom, and on the top, I don't think I have it loaded because these are demonstration cases. Oh, no, yes, I do. Good. we always, it's very, very important to have prior exams, okay? And we load 2 sets of prior exams, one from the immediate year before and one for about 4 or 5 years earlier. Why? Because sometimes changes are subtle. And people who see us every day, Gordy, have no idea that we're getting gray.
Thank God for small favors.
But if you look at a picture from 5 years ago, it becomes pretty obvious.
Yeah, it does.
And the same thing is true of mammography. There can be some significant changes going on that are subtle, and if you just go back a year, you may not appreciate it. But if you go back 5 years, you may say, wow, there's been a big change there. So that is very important to do that. And additionally, it is important for the radiologist to look at every mammogram with a magnifying glass, because sometimes there are subtle findings, particularly calcifications, that you're not going to see unless you look with the magnifying glass. And again, as I was saying, most of the time we're doing screening mammography. So what we do is we look at the current mammogram, we look at the prior mammograms, we make our assessment. This is a mammogram that I had looked at earlier, and I already put some marks on it. I don't know if your camera can see that, but there is particularly a density here that I don't see a comparable density on last year's exam. Okay? And it's also what's called an asymmetric density. There's a density here that isn't in the other breast. This is the right breast, this is the left breast, this is the right breast, this is the left breast. There's a lot of symmetry, just like our faces are bilaterally symmetric. They look the same on one side as they do on the other. The breasts, curiously, are very much the same. This is the right breast, this is the left breast. You can see how the densities almost match. And that, again, is very helpful. If you see a density on one side that you don't see on the other. And anyway, in my mind and I have highlighted what I think is a suspicious abnormality. It is dense, it is spiculated, or causes architectural distortion, and it is new. So I've got to find out what it is. In the other view, I'm not quite sure where it is. So after I've made my assessment, I have a barcode that is provided to me after they've loaded the mammograms into the reader out there. And I simply go like this, read the barcode, and then you like the touch screen, touch the screen.
Isn't that amazing?
And that reading comes up. And I hope you can see with your camera, but there are marks that the reader has placed. It has placed 5 marks. And it puts a triangle where it sees calcifications. It puts a star where it sees a density. It puts a circled star where it really thinks something significant is showing up. And you can see, fortunately, it put a circled star where I put a circled star, if you will. So we both agree.
How do you argue with a machine if you didn't, right?
Well,
Hold on one second. We just want to let people know, we pause for a moment, to let people know that these pictures are taken from the archives. We save a lot of images here. Once you take them, they're saved for a while, right, Doctor?
Yes, they have to be saved for at least 7 years, and as I said earlier, they're very important to compare to other films. And even if there's someone new to the area and they've had mammograms elsewhere in the country, we will call for those mammograms.
No kidding.
That is a standard, that is a required standard of practice. The Women's Imaging Center, as most, if not all, mammography centers now in the United States, are federally accredited. We are all looked at. The machines are looked at. All of us who worked here are looked at every 3 years, evaluating our work, evaluating the machines, seeing that things are up to standard, and then we are recertified for 3 years. And as part of that process, it is expected, it's a requirement that you, if possible, get old films for comparison, as we say it, and other facilities have to accommodate that. If you call for old films,
wonderful.
there's actually a penalty of fine if you do not accommodate another facility's request for comparison, because it is very important. Fortunately, most of the things we chase, and this is a good message to the women in the North Country particularly, most of the things we chase turn out to be benign. So when you get a message to come back and get some additional films, try not to get too nervous about it, because most of the time it's going to turn out to be benign. And also, on the other hand, if it does turn out to be something bad, we have a cancer center, we have full facility here to take care of the problem. To get back to where we were, after I make the evaluation and the R2 makes the evaluation, and we find something of significance, I will give a reading that will say, please get this patient back for additional evaluation, and we're going to find out what this is. We may use additional x-rays, additional mammograph films, we may use ultrasound, but we're going to find out what this is. We may have to go on to a biopsy. And all of those things are available here at the Women's Imaging Center, and we try to service a patient on the same day. When they're called back, we try to resolve the problem so they go home knowing one way or the other that I'm normal, I have nothing to worry about, or I do have some additional evaluation, may have to see a surgeon or have a biopsy.
Well, obviously, the earlier you find that abnormality, the better off everybody is.
Absolutely, Gordy, and of course that's true of all cancers, and that's why screening for other cancers is practiced as well.
And, you know, we're gaining ground on cancers every year, and that's what pleases me.
Absolutely, Gordy. And this is the thing we have found is, like many places else in life, when two people will look at something, in the end you may get a better evaluation. The same thing is true of mammograms. If two people look at it, the chances of you picking up a significant malignancy increases by 10 to 15%. The R2 reader functions as that second person, that second reader. It is also, fortunately, a tireless a motionless reader.
It's wonderful.
It's
isn't it?
wonderful. Doesn't show up having a bad hair day, and is very reassuring to us. I really appreciate it. And again, I say thank you to the people of the North Country.
I wondered, strictly from a personal point of view, what your reaction was when it was first suggested here.
Oh, no, it's excellent. I think that we as physicians and radiologists have supported this effort for years, and really it's radiologists that have developed this. What has taken time is this machine, like the Women's Imaging Center, is federally approved. This needed FDA approval. And as far as I know, this is the only company, the only machine presently in the country that is FDA approved. There may be a second one very close, but it is a tremendous additional help. There's no question about it, and very reassuring. I will tell you this, however, fortunately for job security, it's not a radiologist. It does not read your mammograms. There are some things that it doesn't do, okay? It only looks at one mammogram and tells you what it sees there. It doesn't look at the other mammogram and correlate that, okay? It doesn't know the patient has had prior mammograms, and it doesn't compare those prior mammograms to the present mammogram. It doesn't know the patient's surgical history in particular, and surgical lesions, post-surgical scars, can look exactly like cancer. And unless you know someone has had surgery in that spot, you will think a lesion looking very much like this one is cancer. So it does not do those things. What it does is look for suspicious findings, period, and over and over and over again. And we a little bit check on it, it checks on us. And we already know from people who've worked with this that it is a little bit better at finding very small calcifications, which may be a sign of cancer. We as radiologists are better at finding masses. So a little bit we're working, hand in hand, helping each other out. Teamwork. And again, the benefit is that, two sets of eyes are going to do a better job in the end than one do. And again, the R2 reader functions as that second set of eyes.
I never asked why it's called the R2 reader. Does anybody know?
It means second reader, as far as I know.
R2,
yes,
R2.
The second reader. And again, it is called computer-assisted detection. It's not called computer-assisted diagnosis. It doesn't make a diagnosis. It just looks for these suspicious things. As I said, it's looking for Waldo like we're looking for Waldo. And most of the time, Waldo is not on the films, I'll tell you that. But that's what it is doing.
Well, we're glad it's a welcome asset. We're glad you enjoy having it here, and we know from our viewers' point of view, it's got to be a plus for them.
No question about it.
That's
no
great.
question about it.
Doctor, thanks again for allowing us into your little Casbah.
Thank you very much, Gordy. Thank you.
Liza Rushford, I'm not going to keep you out in this cool February air more than just a moment, but I do want to say thank you so much on behalf of Calvin and myself and Hometown Cable and all the thousands of potential viewers in the North Country. You've made us feel very good about what you've shown us today.
Well, thank you. We're excited about this, the technology that we have to offer, and we just want to let everybody know about it. And we're glad that you gave us the opportunity.
For all those people who ran away from our microphones and our camera today, tell them they don't know what they missed, will you?
They missed a lot.
Thanks again, North Country, for watching our program. We encourage you to give us your comments anytime. And who knows where we're going to be next time for our little corner.